Sure. So patients with renal disease, kidney disease, probably once their function gets to about 50% of normal, lack the critical hormone known as erythropoietin for making red blood cells. Up until late 80s, when that became available, erythropoietin became available in recombinant form, anemia was probably one of the most challenging aspects of kidney disease because we only had transfusions of iron or blood, which was not in itself a very difficult thing. So dialysis patients, even patients before they were on dialysis, had significant anemia, which affected their quality of life. And it is fairly across the board for patients with advanced kidney disease. Right. So one would be the fact that they don't make enough of that hormone. But at the same time, in order to try to make red blood cells, they use up their existing iron stores. So they're always in a sort of negative iron balance. So it's a two-pronged thing. One is iron deficiency, and the other is lack of erythropoietin. In addition to that, these patients are more susceptible to losing blood. If they're on dialysis, they get large needles put in 3 times a week, and they're also at higher risk of losing blood through their gastrointestinal system. And in addition, they generally don't eat as well, so they don't get the amount of iron that a normal person on an American diet would be getting. Presently, we look at two things in general. One is the patient's iron stores, which is in itself challenging because there are markers of iron that suggest the patients may have too much iron when they really have insufficient iron. That is sort of a paradox, and we're not quite sure what to do. So we generally replace iron intravenously even and orally, even when patients appear to have too much iron. It's a difficult clinical situation, and we're looking to determine non-invasive ways of determining how much iron. And then the other is to replace erythropoietin. We call that erythropoietin stimulating agents. And there's a number of them on the market. They're very effective. We administer them to the patients either prior to being on dialysis if they need it, or while they're on dialysis, and they can be given intravenously. They can also be given subcutaneously. And now there's an entire new field of drugs that help to with anemia, which are known. There's about 3 or 4 of them that are in clinical studies. Some of them have been completed. These are known as HIF, or hypoxia-inducible factor prolyl hydroxylase inhibitors. And what they do is they help the body use its own endogenous erythropoietin stores. And the nice thing about these drugs is that they can be given orally, whereas the other drugs, which are work a little bit differently, can only be given through an injection. So none of those are commercially available. There's a number of clinical trials. There's about 4 or 5 pharmaceutical companies that are making them, and they seem to be very promising. And perhaps that's a future in addition to iron replacement, which we talked about a little bit earlier. On a very basic part is that we need, from a laboratory value, we need to be constantly checking patients' iron levels and their hemoglobin. Then if we were going to be giving them some form of erythropoietin stimulating agents or iron supplementation, there would be significant costs on the pharmaceutical end as well as on the administration end. In addition, when patients are anemic, we often have to look for the source of anemia, which involves checking their GI tract. So they may need to have endoscopic evaluations. And often, if they're symptomatic from their anemia, they are admitted to the hospital and given transfusions both of blood and iron. So the costs are very, very significant, and something that the Medicare is looking to be able to help tamp down.